Hello, and welcome to another edition of Whoa, Let's Talk SADS Live, the Canadian SADS Foundation webcast. I'm your host, Dr. Shu Sanitani. Delighted to be coming to you live from Vancouver, and we are live streaming this on several platforms. And thanks to those of you who are joining us live. And I know we also have this for later playback on several platforms. Um, so excited to be here and have another episode. We'll just jump right in here. I'm going to acknowledge a few of our sponsors. Very grateful for Lexio Therapeutics, Solid Biosciences, Tenaya, and Thrive, all of whom are doing exciting research in this sudden arrhythmia death syndromes, SADS conditions, which have impacted so many of you and your families, and exciting times upon us. We're talking about gene therapies and new molecules and trials and lots of development in this space. And as I mentioned, we're streaming also on Spotify, YouTube Music, and Amazon, so you can tune in later on your drive home from work or your commute, or even just at home with your family. So, and thank you also to our partners in SADS US who have been wonderful supporters in getting us going. Next month, we're going to feature a conversation with Dr. Andrew Landstrom, who is a well-known inherited heart rhythm specialist, does a lot of amazing research, and he'll be with us next month, August 19th. Today, I'm very excited to have Dr. Danna Spears join us, and we'll bring her forward into the studio. She's a cardiologist at Toronto General Hospital and an associate professor at the University of Toronto. And I've known of Dr. for many years, so really delighted to have her here. So as she comes in the stage from over the web, it's the way the web is being. There we go. Welcome, Dr. Spears.
Hi, Shu. How are you? It's very nice to be here today to speak with you.
Yes, thank you so much. And I didn't do your introduction much justice because I thought we'd have a little conversation about how you got to be where you are. So take us back a little through your journey. Where did you do med school? When did you realize that you were going to become a cardiologist?
Well, it's funny how we all come through these circuitous routes. It feels like to come to our final landing spot. But yes, I was an internal medicine resident, and then found cardiology because I had an affinity for electrophysiology. Really, for my whole history through biochemistry in my undergrad, where I went to McGill University. And then I did medical school at Queen's. And again, going through medical school, you do kind of keep your eyes open. And I also had an interest in maternal fetal medicine and obstetrics. So it was when residency and fellowship were really coming together that this thought of pregnancy and arrhythmia management became very appealing to me. And so I did the first few years of my fellowship in electrophysiology and ablation at Toronto General. But then, in order to be able to get a little bit more experience with genetics and inherited heart disease, I spent some time in Pavia in Italy, studying with Dr. Silvia Priori and her team there, understanding a bit more about genetics and this sort of branch of familial medicine. When I came back to Toronto, as you know, we have a strong congenital heart disease program, and the program that manages pregnancy in women with structural heart disease. And there was a real gap there in terms of managing patients with arrhythmias. Now, either simple arrhythmias like supraventricular tachycardias, ectopy, things like that, but also moving more into the inherited heart conditions like long QT syndrome, CPVT, the inherited cardiomyopathies. There was really a gap in care provision at our center. And so that is what really inspired me to start looking at working with our pregnancy program very early in my career, to start looking after these women. And I've been incredibly lucky to have such a close relationship as well for the hospital with the Hospital for Sick Children, because we've had the ability to really offer genetic care all the way, from pregnancy and managing fetal issues through, very young children at the Hospital for Sick Kids, and they come then back to us through Toronto General Hospital. And, we've actually now reached the point where some of our earliest patients that came through the Sick Kids program are now having their own children. And so it's really been an incredible journey to be able to create this program where we really try to deliver care, from the beginning of life right up until the very end, looking after families and through all their stages of life. And so that's kind of how I came to be in this current environment.
Wow. So quite a pedigree, and I didn't realize that you'd spent time with Dr. Priori, who of course we've mentioned on this show several times. She's a real ceiling breaker and leader in our field. So, well, that's amazing. And so, tell us a bit about so. Why are we even talking about SADS conditions? I mean, a lot of the people out here in our audience already have families. So, you know, it, why do we talk about pregnancy in SADS conditions? Is it a concern? Um, Tell us a bit about sort of what your clinic's role is in this.
Well, when I first came to this and started speaking to other people, around the country and also at international meetings when we are looking at these types of conditions in pregnancy, there are really two things that have struck me. One is the number of women who have been discouraged from wanting to start a family on the basis of their genetic heart disease. And, there's a lot of fear and a lot of knowledge gaps when it comes to these conditions, particularly as they pertain to pregnancy. And I think that fear often drove women and their practitioners away from being supportive of pursuing fertility and pregnancy and growing their families. And so that has been something that I have found to be quite rewarding, because the second aspect of this is that even though there's a great amount of fear and trepidation in the general practice population dealing with these conditions, in the vast majority of cases, they're remarkably low risk to be managing these women through pregnancy. Now, of course, I'm not talking about complex congenital heart disease, but a lot of the inherited heart conditions that we're managing on a daily basis, whether they're the inherited cardiomyopathies or primary arrhythmia disorders, there are ample ways to be able to navigate a pregnancy with these conditions to arrive at a successful and safe outcome. And I think that has been something that, to be able to offer that to our OB community and to the families out there who want to start growing their families, that's really been something that I've been pretty proud of. And I think as a community in Canada and the United States, to be able to help OB doctors navigate this environment to take care of their patients has been a real service. I don't mean to sort of toot my own horn here, but I do think that we've done something good here, and we've been able to offer a lot of support through pregnancies for these women.
I think you should absolutely be promoting your work. It's very important, and that message of fear is out there, and it's very evident. And I've had families contact me and say, should we have children? Should we, carry on with this pregnancy? Because they're very scared of the potential risks of passing the condition on most often. Let's start though. Let's talk a bit about the mother in this. What are some of the things that you have to do to ensure that a pregnancy is safe? For example, a lot of our families, a lot of our patients are on beta blockers. So conditions like long QT syndrome or CPVT, catecholaminergic polymorphic ventricular tachycardia. We have people who are on medications. Are these medications safe to continue? Do we have to, adjust medications, things like that?
Absolutely, and I think that that's another really important issue, because we have a very good understanding and a lot of robust science to support medical therapy for these conditions. And again, there's a great deal of trepidation with continuing these medications or initiating potentially life-saving medications, both during pregnancy and also for those who are breastfeeding after delivery. And so helping to clarify what is safe and what can and should be continued, and safe alternatives for some of these medications, is also an important part of what we do and how we support these families. So for example, in long QT syndrome, well, first I guess we can start with any of these conditions that benefit from beta blockade in terms of a mortality benefit for the mother. There are there's a lot of experience, particularly with some of the older beta blockers that we use, particularly for long QT syndrome. And so something that's important to understand for long QT syndrome is some of the newer beta blockers, such as bisoprolol, carvedilol. These drugs have not been well studied in pregnancy, well studied in long QT syndrome, and even less so in pregnancy. And so typically we will reach back into our bags of old beta blockers for these conditions. And these are the medications that tend to have a stronger track record for safety and mortality prevention in, I'll use long QT syndrome because that's the best studied condition that we deal with. And so, for long QT syndrome, the more non-selective beta blockers tend to be preferred in terms of their outcomes for managing long QT syndrome. And historically, these have been propranolol and nadolol and atenolol in the non-pregnant population, whereas we know now that atenolol does cause unacceptable degrees of intrauterine growth restriction. And so this is not a beta blocker that we use so in pregnancy. And so recognizing, a woman who may be treated with atenolol prepartum, we know that we have to get her onto a stable dose of a safer beta blocker for the course of her pregnancy. And particularly in the postpartum period, where the risk of syncope or cardiac arrest is much, much greater in long QT syndrome. Now, there are some issues. For example, nadolol is one of the more frequently used medications, particularly for CPVT and in higher risk long QT cases. Now, nadolol historically has been, there's been a lot of trepidation about using nadolol during pregnancy because of its potential for intrauterine growth restriction, as in any other beta blocker. However, in the last the last 5 years, there has been a publication where there's been a really close look at the use of nadolol in pregnancy, and there really is no difference in the degree of growth restriction when nadolol is used compared to, for example, metoprolol or propranolol. And so we are starting to see more evidence of safety and efficacy of these medications in pregnancy. And so there should be absolutely no concerns about adequately protecting your patient with an inherited heart condition with a beta blocker. Now, certainly, it's very well described and accepted that beta blockade can cause lower birth weight babies. However, this is not, as long as you're not using one of the drugs that are clearly contraindicated in pregnancy, such as atenolol, that is something that we monitor closely through pregnancy. But again, it's not something that we would refrain from using a beta blocker for, to avoid intrauterine growth restriction. Now, in terms of monitoring the fetus with long QT syndrome, as you know probably much better than I do, in terms of the fetal manifestations of long QT syndrome, we can start to see bradycardia and lower fetal heart rates, particularly in certain subtypes of long QT syndrome. And so that is something that it's really important to have a good relationship with, the adults or maternal fetal cardiologist, as well as with the OB, and the neonatologists who are going to be more closely following these babies in utero, to recognize that the bradycardia associated with a beta blocker is pretty uncommon when we're dealing with these conditions in pregnancy. But when we do see that in long QT syndrome, that can actually be a marker of a higher risk fetus in terms of their long QT phenotype, with respect to a worsening risk of heart block, bradycardia, or arrhythmias, either in utero or as a newborn. And so it's really important to have a good relationship with your, with the whole team looking after these patients, because in order to be able to interpret findings correctly, and to, for example, in a situation like that, not remove the beta blocker, but to recognize that you may be dealing with a higher risk infant at birth who may need some heart rate support or advanced care upon delivery. So beta blockade, absolutely. I would have no fear about using these beta blockers. And if you're in a situation where you are dealing with a higher risk arrhythmia subtype, then it would be important to seek care, to seek an opinion or care with one of our obstetric programs, such as what you have in Vancouver, and there are many through cities, in North America, and particularly in Canada. So never to be afraid to ask for help or get an opinion to share care through a pregnancy.
So, yeah, thank you. We covered a lot there, and I want to come back to some very important points. Firstly, that it is safe. I'm hearing that in an ideal setting, planning for the pregnancy or anticipating it may be the preferred way if you're going to have to have a multidisciplinary team engaged early on, and if you potentially might even want to switch your beta blockers very early in the pregnancy, because of course so much of that growth is going on even before you're pregnant, or before you're showing. So so I think planning, having access to a specialist clinic, and it's good to know that Canada is fortunate to have people like you, and I know we have a similar facility in Vancouver. So um, let's talk a little bit about the delivery part of it, and I want to sort of can these women with long QT or CPVT, can they deliver in regular hospitals? I mean, I know it will depend a little bit from patient to patient, but is the actual sort of is the act of childbirth a dangerous event?
No, that is really one of the most important questions that we answer during our consult periods when we're dealing with these inherited heart conditions. So I think we are in the same sort of situation across Canada, where we have a huge landmass and population spread through very far north areas, very rural areas that may not be immediately within our catchment areas for these large, maternal fetal medicine or obstetric centers. And so one of the important things that we do counsel on and plan for is higher risk pregnancies that will require cardiac telemetry and more advanced, potentially obstetric and cardiac care during labor and delivery. And those women who are stable and low enough risk that they can deliver at their local obstetric center, but without the need for cardiac telemetry and cardio obstetric care, during that whole period around and immediately after delivery. And so for long QT syndrome in general, my rule of thumb is that if there has not been a history of cardiac arrest, if they have stable cardiovascular findings. So as you know, some subtypes of long QT syndrome will have more aggressive ventricular arrhythmias, heart block, bradycardia. For example, those women I am a little bit more cautious with, but those are the rare cases. The vast majority of women with long QT syndrome, when they're stable on a beta blocker, then in general, I don't recommend cardiac telemetry for those women as long as the pregnancy is uncomplicated. So, as I was mentioning before, if we're also getting signals that we may be looking at a higher risk newborn in terms of arrhythmias or heart block, that's a situation where I would recommend delivery in a more tertiary care center. Whereas absence of significant arrhythmias, stable on beta blocker, no high risk features such as recurrent syncope or cardiac arrest, those women I feel fully comfortable to have them deliver in their local obstetric center. CPVT, that's an interesting one, because as you have published actually in your center, the CPVT pregnancies also tend to be lower risk. Now, this is a very arrhythmogenic inherited heart condition, and the phenotype there is increasing arrhythmias with increasing catecholaminergic stress. And so you would think that pregnancy and labor and delivery would be a prime time for arrhythmia complications because of that catecholamine excess that we expect around labor and delivery. I'll say, though, that many women historically, especially if they've been well beta blocked, and when I say well beta blocked, what I typically do in our CPVT population, particularly if we're planning a pregnancy, is we ensure adequate beta blockade with Holter monitoring and with regular exercise stress testing to ensure that we are not getting any runaway arrhythmias with increased catecholaminergic tone. If there is a history of cardiac arrest or a history of syncope, a history of poor compliance with medical therapy, then I would be far more likely to recommend delivery at a more tertiary care center where we can have cardiac telemetry during labor and delivery. I will tell you that even though we've had many pregnancies that have been either very successful with beta blockade, or women who have delivered, and the first sign of CPVT in the family can come as the offspring of one of these women, and their diagnosis was unknown at the time of their pregnancy, which is I would say in our program, the vast majority of our patients, their parents were it was unknown that either of them had CPVT, and it just became phenotypically apparent in the child. So we know that there's a long history of safety with CPVT in pregnancy, but I do have a lower threshold for cardiac telemetry during labor and delivery in CPVT. And you also have to remember that we're managing these patients from a cardiac and arrhythmia perspective, but we also have our obstetric and anesthesia colleagues out there managing these women during their labor, and we'll have many cases where their OB just won't feel comfortable delivering them in a local sort of OB center, and for those reasons we do accommodate many more higher risk arrhythmia patients who would otherwise be okay to deliver in the community with adequate beta blockade, but out of preference for the obstetric team, we will bring them in and have them deliver under telemetry with us. And so those two conditions can have a wide spectrum of being much higher risk versus a very standard risk from an OB perspective. And those are the two sort of arrhythmia conditions that we deal with. The cardiomyopathies can be a little bit different, but for those two conditions, that's our practice, at least in Toronto.
And that, and I'm sure that, again, the ability to consult with a team like yours and then potentially be reassured to go back to, deliver in their home community is another important aspect of this program. Let's talk for a moment about defibrillators. So some of our patients, who have presented with, severe forms of SADS conditions, they end up with an implantable cardioverter defibrillator, or ICD. Some will have pacemakers, but it's not uncommon for a young woman to have a defibrillator in place. Can one approach the pregnancy similarly? Does the ICD change things much?
That's a very interesting point, because there is this perception in the community that a woman who has a defibrillator may be at higher risk for the course of their pregnancy, where actually the converse is true. When you take women who are matched according to their underlying cardiac condition, arrhythmia burden, etc., women with a defibrillator have far better outcomes than women without a defibrillator. And so I think that that's an important message. First of all, that if you have a young person who you feel would be protected by a defibrillator, then planning a pregnancy should not have any impact on that decision making. So if an ICD is indicated for any of these conditions, that should be undertaken irrespective of the planning for pregnancy, and I would say even irrespective of the stage of pregnancy. And so we have had women who have had their first diagnosis of an inherited heart condition or a cardiomyopathy during their pregnancy, and in these conditions we do not wait to implant a defibrillator for them to complete their pregnancy. We do it at the time that we feel that it is indicated to protect them with that device. And so I would have zero trepidation about managing these individuals who have implanted heart rhythm devices, whether it's a pacemaker or a defibrillator. Now, there are certain things that we do need to address in our patients who have a device prior to pregnancy or prior to their delivery. So if someone is planning a pregnancy or is in their pregnancy, I generally will follow them closely to make sure that they have good battery function, that we have good lead function, because the last thing you want to be doing is dealing with elective battery changes or lead fractures and issues like that when you're also trying to manage a pregnancy. So I generally will plan to get all of those things assessed and sorted out prior to delivery or prior to a planned pregnancy, so that if there's anything that needs doing, it can be done prior to those stages. With a defibrillator, there's been a lot of question, particularly as it pertains to emergency surgery. So, for example, cesarean section, and whether, how to manage the defibrillator and what we should be doing about it. The good news is that defibrillators, when they're implanted up on the chest, which is the standard position, this is not referring to to young people who have abdominal placed devices, because the management is a little bit different. But for standard position of a defibrillator that's functioning normally, the risk of electromagnetic interference is extremely low. Particularly, most OB centers are now using bipolar cautery for cesarean section and for delivery, and so that has more of a closed circuit of electromagnetic field, so that it is also much less likely to be detected by the device. So prior to delivery, we will provide the OB team with information about what kind of device the patient has. So, how many leads, whether it's a dual chamber or single chamber device, the programming of the device to know when it's going to start pacing, when it's going to start detecting arrhythmias, and we give some guidance on magnet placement. And so in general, there's always a magnet on the anesthetic cart in most operating rooms, and particularly in our labor and delivery suites. And so just to understand that for a defibrillator to have a magnet over it, that function is going to be to stop detection and to stop delivery of therapies for arrhythmias that may be encountered. And so we generally will recommend that the device not be disabled, which is something that is a frequent request from our anesthetic colleagues, to turn off a device prior to going into the OR. We generally recommend against that, because the risk of an inappropriate shock is so extremely low for sub-umbilical surgical procedures. Plus, if the patient is able to safely and in a stable way have a magnet applied to their device, then if you do run into arrhythmia trouble, which is again extremely unlikely, then the magnet can simply be removed and then you've reactivated the device. It's important to know that with the defibrillator, though, magnet application is not going to force pacing. And so if you have someone very dependent on pacing with complete heart block, for example, then it will be important to monitor the rhythm closely and use short bursts of cautery, again, in the very unlikely event that you're going to see any inhibition of pacing. Pacemakers, very similar, the very low risk of any electromagnetic interference. And again, a magnet application is going to force pacing in a pacemaker. And so having that in the room will also, cover any anxiety for suppressing pacing in the context of EMI. So that's the management of both of those devices. Again, intra-abdominal devices are a bit of a different story for obstetric surgical procedures, because the location of the leads and the location of the pulse generator can be highly variable, so that has to be more individualized. But essentially following through pregnancy with regular device checks to determine the arrhythmia burden, ensure that it remains low, and to ensure the integrity of the system, of the pacing system, is really important. And that's probably the most important thing that we do, is to communicate that to the obstetric team and to reassure them about how to manage the device during labor and delivery. Another question that we get quite frequently is whether antibiotics are needed for a woman who has a defibrillator or a pacemaker. And again, unless there's an indication for antibiotics for infection, endometritis, or if there's some concern about active infection during pregnancy, then of course antibiotics are indicated. But for antimicrobial prophylaxis or endocarditis prophylaxis in labor and delivery, it's not indicated. And so that's another important question that we get. And so no antibiotics are needed if there's no active infection.
So this is wonderful. You're providing such a practical approach, not just for our patient families, but also for healthcare providers that may be wondering about their cases and thing. Again, I'm hearing planning for success is likely to be relatively straightforward and effective. The women who have devices can go through the normal types of labor and delivery and potentially also stay in their home community if we're prepared. That said, often the patients who have these devices have already identified themselves to be at slightly higher risk, and so the care will be individualized. I'd like to talk about a few more things here. We have a little bit of time still. We've talked about electrical conditions, so long QT syndrome and CPVT, where the heart is structurally normal and it does not tend to be impacted as much, the structure of the heart. Let's talk for a moment about arrhythmogenic cardiomyopathy, or ARVC. We've talked about this a few times on this show, and I'm curious if you have some experience or just some general principles. Again, I think obviously cases will be individualized, but arrhythmogenic cardiomyopathy to me is a fascinating condition where the right ventricle is so impacted, and in pregnancy there is so much more circulating blood. I just wonder if if one has to treat ARVC differently, and what your sort of approach is for that.
Well, with ARVC, we do manage the full spectrum of presentation. From, we have many experience with many women who have been found to be a gene carrier for one of the desmosomal gene mutations, but are not yet showing any particular phenotype. And so, for example, a young woman who's a carrier of a PKP2 gene mutation, but MRI has been normal, Holter's been normal, echo's been normal. Those women we still follow closely through pregnancy. I generally will follow them, every trimester. And as you alluded to, we often don't get these referrals until we're about halfway through the pregnancy. And so an assessment there, sometimes we're picking up a little bit of arrhythmia on Holter monitoring, but I have to give the caveat that many completely normal women will have an increased burden of PVCs, premature atrial contractions, and even ventricular triplets or couplets. Obviously, I get a bit more concerned when it's a woman who is carrying one of these gene mutations, but it's really important to step back a little bit and not panic too much, especially if they've been phenotypically completely normal prior to pregnancy, because sometimes women do have an increased burden of arrhythmia. Regardless, these women I follow each trimester, make sure that we're not seeing arrhythmia. If I do see a bit of arrhythmia, then I will have a conversation about beta blockade, saying, it's not possible to say whether this is actually your gene becoming an issue where prior to pregnancy there was absolutely no phenotype, or is this just a normal bit of arrhythmia during pregnancy. But I will have a lower threshold for beta blockade when they are a gene carrier. So that's something there's not a lot of literature on this, but it's something that I, in my practice, do. Then, of course, we move up the spectrum. So we have either gene carriers or individuals who are starting to show an arrhythmogenic cardiomyopathy phenotype. And so the vast majority and sort of this normal distribution will be individuals who have some subtle structural changes, so right ventricular dilatation, some wall motion abnormality, but overall good heart function, maybe a modest burden of ventricular ectopy. in terms of PVCs or, ventricular couplets or triplets. These women, again, I'm very cautious with monitoring through pregnancy just to make sure that we're not missing an increasing burden of arrhythmia as the pregnancy progresses, but also to think about early beta blockade for arrhythmia prophylaxis if we are starting to see increasing arrhythmia. And again, if we are seeing higher grade ventricular arrhythmias, syncope, or decline, particularly in left ventricular systolic function, again, whether they're 30 weeks gestation or 20 weeks gestation, when you feel that a defibrillator is indicated in this condition, then the pregnancy should not have an impact on that. We have implanted defibrillators during pregnancy, if the arrhythmia burden starts to increase to the point that we're concerned about mortality. What's really important to remember in ARVC going into a pregnancy is your greatest predictors of successful obstetric outcome is going to be your initial heart function and your burden of arrhythmia. And so women who have a lot of ventricular arrhythmias prior to pregnancy are going to be higher risk during their pregnancy, and we monitor them with Holter monitoring and beta blockade, etc. And the women who tend to run into trouble when we look at, for example, the Danish study or other larger studies of women going through pregnancy and ARVC, it's really those individuals who have a high arrhythmia burden who are not beta blocked, or those who have stopped their beta blocker during pregnancy. Those are the women who tend to run into arrhythmia complications during their pregnancy or labor and delivery. So it's really important, again, it's a very common thing that I encounter in practice, is that women who are very well managed before pregnancy will elect to reduce or stop beta blockers because of the concern of growth restriction or exposure of the baby to beta blockade. But again, that's actually putting them in a much higher risk situation, and maintaining that arrhythmia stability and arrhythmia prophylaxis is critical to getting these women safely through labor and delivery. And again, women who already have a device, who've had cardiac arrest or sustained ventricular tachycardia or reduced heart function, those women are a bit higher risk, particularly with reduced left ventricular systolic function. I do get worried about those women, because as the left ventricular systolic function starts to go down, their maternal mortality starts to really increase. And so, I'm a lot more cautious, and I'm an electrophysiologist, and so I will seek shared care with our cardiac obstetric colleagues who specialize in heart failure, for example, so that we're managing these higher risk women through pregnancy. But in general, unless their ejection fraction is very poor, so less than, say, 40%, 35%, I have no concerns about getting them safely through pregnancy with the appropriate monitoring. In terms of outcomes, long-term outcomes in ARVC and pregnancy, it's actually quite reassuring. You allude to the fact that the pregnancy is a much higher cardiac output state, which is something that we think about with risk in ARVC over the long term in terms of athletics and competitive cardiovascular activities. Whereas what's very reassuring is that the number of pregnancies and any pregnancy at all does not seem to have a negative impact on right ventricular parameters or arrhythmia, either in the short term or in the long term. And so I think that this is really important messaging that wasn't out there maybe 20 years ago, that women with ARVC in most cases can successfully be monitored through pregnancy and have successful pregnancies and grow their families.
I think that's a very important point for our families to hear, because again, there is a lot of apprehension and fear, but the results are encouraging, and particularly in this multidisciplinary environment where people are paying attention not just to the electrical side, but also the obstetric side and the heart function. And I want to come back to a very important point that you made. Pregnancy has so many expected physiologic changes in those unaffected by heart condition. Blood pressure changes, fatigue, swelling, and fainting episodes, all of these things, extra beats, abnormal heartbeats. And so we don't want to have the beta blocker be a scapegoat for some of this. in those in particular who need the beta blocker the most. So, for our families to to really kind of keep that in mind, that the beta blocker is often the easiest thing to change, but probably does not need to be changed and shouldn't be changed.
Absolutely.
Just as we're wrapping up, I want to come back to, now you mentioned in long QT the postpartum period. So of course, we've focused on pregnancy, but the postpartum period is of particular interest in long QT syndrome. So I wonder if we could just talk a bit about that and how you manage that, as I'm sure your clinic has to slowly step away from these women who have completed their pregnancy yet remain in a risk time.
Absolutely. And I think, I don't think a lot of people realize that for long QT syndrome, the highest risk time is actually in that first 9 months after delivery. And there has been also a lot of sort of old wives' tales about managing the postpartum period, particularly as it pertains to breastfeeding in women with long QT syndrome. Now, that the story about breastfeeding, this myth that it creates a higher risk environment, probably came from the fact that women who were postpartum with long QT syndrome had a higher risk of cardiac arrest. And statistically, when you have a young baby that is breastfeeding dependent, you're probably spending 20 hours a day breastfeeding. And so this pattern of risk and breastfeeding emerged sort of through the medical mythology, that this was something that needed to be avoided in order to protect the mother with long QT syndrome, and that really doesn't seem to be the case. Now, it's fascinating, and I'm not sure that we completely understand the pathophysiology of the increased arrhythmogenesis postpartum. We do know, for example, that oxytocin can have some function in terms of channeling, of moving ion channel proteins to the cell membrane, in animal studies, as well as changing levels of estrogen and progesterone and their electrical, changes of electrical gradients on the myocardium. But again, all of this is all theoretical, and it's not well understood at this time. What is well understood, though, is the protective ability of beta blockade postpartum. And so we speculate on the mechanisms of risk, but the fact is that there's very clear, long-standing and duplicated literature to show that women who are adequately beta blocked postpartum have a much, much lower, almost back down to baseline risk of syncope or cardiac arrest. And there are individuals who do not want to participate in beta blockade, and in these individuals, I will really try to have a conversation about even initiating beta blockade late in pregnancy and continuing for that first year, to give them maximal amounts of protection. Now, it's not very common that we have individuals who are very averse to using beta blockade, but in those conditions, I really try to impress upon them the fact that postpartum is going to be critical for maintaining that beta blocker. In terms of breastfeeding, again, beta blockers have a long track record of safety in breastfeeding. The beta blockers will get into the breast milk to a very small degree. Nadolol will get into the breast milk a little bit more than propranolol will, but in high-risk women, this is still something that I use. I will use some caution if we're dealing with a very preterm baby or a young baby that has poor renal function, just because this is how nadolol is excreted. Or if there are severe gut issues, because there have been case reports of nadolol kind of sitting in the baby's gut for a prolonged period of time if they have, gastric stasis or other intestinal issues. But still, with specialized care with an electrophysiologist or pediatric cardiologist, these women can be protected and continue to breastfeed and take their beta blockers through the postpartum period to maximize their risk to minimize their risk of mortality and an adverse outcome.
Well, Danna, it's been an absolute delight speaking to you today, and I think we covered a lot of really important principles. And most of this is good news for people who are planning families, affected by SADS conditions, and that pregnancy is is generally safe. There are teams out there who can really, manage the nuance elements of this. And, as with everything in life, I suppose, a bit of planning will go a long way. And it's been great to talk to you. And I think this episode will be on our website and can be a resource for people who may not quite be in the family planning stage yet, but we'll get there. So thank you.
Oh, my pleasure. My pleasure.
So that's our show for today, and I wish you all a good summer, and look forward to seeing you next month in August with Dr. Andrew Landstrom. And please click on the SADS website and browse some of our literature and our past recordings, and consider making a donation to support being able to disseminate information like this and to support families like yours who are hopefully thriving with SADS conditions. So thank you very much. Goodbye.